For those of you who don't know who I am, I'm Shoaib. I'm one of the co-founders of BiteMedicine, and we are continuing on some hematology lectures. Today I'll be covering platelet and clotting disorders. Just some housekeeping announcements before we get started. Of course, we're running the webinars which are streamed via our website. If you are having any difficulties with the audio or the visual side of things, there should be a link just below the stream. It should say meeting info. If you click on that, you'll be able to access the Zoom link. And if you have any issues with the integration on the website, please do feed that back to us at the end on one of the feedback forms, because that's extremely helpful to all of us. But without further ado, we have quite a lot to cover today, so let's get started. I think Azim's in the chat. If you can ask your questions in the Q&A section, and either me or Azim will try and get to them. So today we're going to go over the clotting process, or how the platelets and the coagulation cascade fit together, and how pathology results in bleeding disorders. In the next session, we'll look at fibrinolysis and thrombophilia and hypercoagulability. So today we're focusing on bleeding disorders, and next session we will focus on disorders which make you prone to clotting. A lot of these conditions that we're going to cover today, you don't need to know in depth, so I'm just going to cover the high yield facts that you need to know for your exam. Hematology is a complex subject, especially if you get bogged down with the details, so just learn the high yield facts. And I must be honest, hematology I actually really do enjoy, but I would say the one part of heme that I did find difficult at med school, and still find a little bit frustrating at times, is the whole coagulation cascade. So hopefully I've simplified it in this lecture. I mean, it'll take about an hour to an hour and 10 minutes, and the slides are up on our website. Just one second, I just need to... Okay. Fine, let's get started. So this is the first case. You have a 6-year-old boy who's brought into the GP by his mother. He has multiple pinpoint hemorrhages, which are shown here on the diagram, and bruising. He's had a nosebleed today, which is unusual for him. You look at his notes and he shows that he's had an upper respiratory tract infection 2 weeks ago, but is otherwise well. Don't state the diagnosis or anything in the chat, but are you guys worried or not worried? Is there any cause for concern? I think we've got not really. We don't have the obs here. Okay, so we've got a mix. Let's move on to the question. So again, please answer on Menti. I'm going to switch over to Menti now. Which of the following is likely to be affected in this child? So if you go to menti.com and use the code 4998, you should be able to access the questions. The easiest way to probably do this is using your phone. So which of the following is likely to be affected in this child? 6-year-old, multiple pinpoint hemorrhages, had a nosebleed, an upper respiratory tract infection a couple of weeks ago. Platelets, factor VIII, white blood cells, plasmin, or thrombin. So we have a few things there. Let's see what you guys think. So most of you gone for platelets. What condition do we think this child has? So ITP, good. So this is a platelet condition, and I'll explain why. If this is all foreign to you, don't worry. That's the purpose of this lecture. Don't worry if you got it wrong. So factor VIII would be the next best guess. That's the coagulation factor. That presents differently, as we'll go on to find out. White blood cells, so this is a bleeding problem. So therefore, it's either going to be platelets or coagulation factors. And again, it's not plasmin or thrombin. We will discuss that now. So platelets classically present with petechiae and epistaxis. Those are the two classical symptoms and signs of a platelet or thrombocytopenia condition. The history suggests ITP, which stands for idiopathic or immune thrombocytopaenic purpura, which we will come on to later. Factor VIII, as I said, is coagulation, cascade pathology, and that normally presents with deep tissue bleeding. So deep tissue bleeding, things like hemarthrosis, so bleeding into the joints, bleeding into muscles. That's how haemophilia typically presents. Haemophilia is factor VIII deficiency. White blood cells, as we said, this is a clotting problem. It's not plasmin. You know, this history clearly points towards a diagnosis of thrombocytopenia. And again, it's not thrombin, okay, because it's a platelet problem, not a coagulation cascade problem. So what in the history suggests that this is a platelet problem? Well, this is what petechiae look like, pinpoint hemorrhages. This is classic of thrombocytopenia. If you have low platelets, you're not going to be able to repair small hemorrhages, and you're going to get blood cells leaking out into the extravascular space, forming these little dots, and they are known as petechiae, or pinpoint hemorrhages. Patients will, of course, be prone to bleeding, bruising, and epistaxis or nosebleeds are very common in platelet disorders. A lot of you said the condition is ITP, idiopathic thrombocytopaenic purpura, and the history is classic. It typically develops following an upper respiratory tract infection in children. Again, we'll go over ITP later, so don't worry if you have no idea what it is. I can see some of you asking HSP. So HSP is different, okay? It presents differently. It's a vasculitis. You get purpura. You don't get these pinpoint petechiae. You might do, but you most typically get bruising and purpura on the buttocks and on the thigh. And it can present with a few other symptoms as well. And also HSP wasn't an option on the question. So what is hemostasis? So it's damage to the blood vessel wall, which is then repaired by thrombus formation. It occurs in two stages, primary hemostasis and secondary hemostasis. So primary hemostasis, you get platelet plug, and secondary hemostasis, you get stabilization of that platelet plug, and that involves a coagulation cascade. So primary, we're dealing with platelets, and secondary hemostasis, we're dealing with coagulation cascade. And this is how a clot forms. So a bleeding disorder can either be a defect in the primary hemostasis pathway or the secondary hemostasis pathway. So i.e. bleeding can be due to a platelet problem or a coagulation cascade problem, or a combination of both. And that's the way you should categorize it in your head. Hopefully that all makes sense so far. Fine, so what is primary hemostasis? What do the platelets do? What is their role in forming a blood clot? Whenever you have vessel injury or trauma, the first thing you get is vasoconstriction. Obviously, you want to limit the blood supply to the affected region to minimize blood loss. So this is a reflex. You get vasoconstriction of the affected area. You then get platelets adhering to the blood vessel wall. The platelets then release a bunch of chemicals. ADP and thromboxane are two of those, but there are many. Those chemicals then promote platelet aggregation. So the platelets start to clump together. And that's primary hemostasis in a nutshell. But of course, we need to go into things in a bit more detail. So let's have a look at what I mean by platelet adhesion. So platelet adhesion means the platelet, which is this red blob here, binds to the blood, the affected area of the blood vessel. When you have any trauma or damage to the blood vessel wall, endothelial cells are damaged and you get exposure of collagen, which lies underneath the endothelium. The endothelium is just the lining of the blood vessel. So upon any trauma, you get exposure of subendothelial collagen. You then have this thing called von Willebrand factor, which is a protein, and it's made in platelets, and it's also made by endothelial cells. So when you have trauma and exposure of the subendothelial collagen, von Willebrand factor binds that collagen, and it also binds the platelet. The platelet sticks to von Willebrand factor through this receptor GP1B. This is all important because all of these receptors and these proteins, they'll pop up later in various different diseases. So the point is the platelet binds the affected area via the GP1B receptor, which binds von Willebrand factor. So that's platelet adhesion, when the platelet binds to the blood vessel wall. So what's next? Platelet degranulation. The platelet, once it's bound to the von Willebrand factor, it will start to release a bunch of chemical mediators. That's known as degranulation. There are a bunch of chemicals, but the two important ones that I want to highlight here are ADP and thromboxane. So TXA2 stands for thromboxane. So as we said, adhesion induces platelet degranulation, and you get a release of a number of mediators. These mediators are very important in causing the platelets to stick together. They're very important in platelet aggregation. So ADP activates a different receptor, the GP2B3A receptor. So not the GP1B receptor. There's a different receptor which is coming up called GP2B3A. And thromboxane enhances fibrinogen binding. So what does this all actually mean? Well, if we look at the platelet aggregation stage, remember we said ADP activates this GP2B3A receptor, and that's here. That receptor binds fibrinogen, and through the platelets binding fibrinogen, they become stuck together. They aggregate, they clump together. Thromboxane is also very important because it enhances this binding of fibrinogen to the receptor. So these two mediators, which are released in the degranulation stage, are very important in causing the platelets to clump together. The overall result is that you have a bunch of platelets stuck together, and that forms a weak platelet plug. Okay, so this primary hemostasis creates a weak plug which will temporarily halt the bleeding. In order to strengthen this platelet plug, you need the coagulation cascade. So that's primary hemostasis in a nutshell. That's everything you need to know about primary hemostasis. And all of these little chemicals, GP1B, GP2B3A, they're all important because they all crop up later when we're discussing various diseases. I am going to ask this question now. So what's the role of antiplatelet agents? Where do they act in this process? So name some antiplatelets and how do they act in this whole primary hemostasis mechanism? So we've got aspirin. So what does aspirin actually do? So good, aspirin knocks out thromboxane. It's a COX inhibitor. We'll come on to this later. It knocks out thromboxane. What does clopidogrel do? So some of you mentioned clopidogrel, but no one's actually mentioned a mechanism for clopidogrel as far as I can see. So it knocks out the function of ADP. And finally, what's the final antiplatelet agent that will act on? So we have GP2B3A inhibitors, which actually block this receptor, and an example would be tirofiban. So that's where understanding the basic pathophysiology and all of the receptors are really important in understanding how the different drugs work and how the different diseases occur. So yeah, some of you are still naming some good examples. I hope that's all clear. And we'll come back to the medications in a bit. But that's primary hemostasis. You get the vasoconstriction, the platelets then adhere to the vessel wall through von Willebrand factor and the GP1B receptor. The platelets then release a bunch of chemical mediators such as ADP and thromboxane. And eventually you end up with a platelet plug, which involves platelets bound to fibrinogen. Okay, so we've gone over primary hemostasis. We understand that it results in platelet aggregation. Before we move on to the coagulation cascade, I actually want to tackle all of the primary hemostasis disorders, because this is going to make the most sense to do it in this order. So primary hemostasis disorders basically mean anything which causes your platelets to get messed up and results in bleeding. We can further classify platelet disorders into quantitative or qualitative disorders. So quantitative disorders are ones which reduce your platelet count, and qualitative disorders are ones where the platelet count is normal, but for some reason they aren't functioning properly. So quantitative thrombocytopaenia, qualitative, the actual platelets are not functioning properly. And we have 7 conditions here. So the 4 on the left all cause thrombocytopenia. The 3 on the right all cause impaired platelet function. And don't worry, we'll go over the medication stuff again in a few slides. Okay, so quantitative, qualitative, that's the way you break down platelet disease. And platelet disease comes under primary hemostasis. So that's the way you categorize this. What are the clinical features of platelet disease? So the classic symptoms and signs are highlighted in bold. You get early bleeding post-trauma. You're unable to form that weak platelet plug. The platelets don't come and stick together properly, so you get early bleeding post-trauma. Nosebleeds, also known as epistaxis, are very common, and you get petechiae, those pinpoint hemorrhages. So those are your common signs and symptoms. Of course, you can get other things like GI bleeding, menorrhagia, bleeding from dental extraction sites is a common one in exams, easy bruising. Purpura and ecchymoses are just bigger, basically they're bruises. So petechiae are pinpoint hemorrhages in the skin, and purpura and ecchymoses are slightly bigger. So on the left here, we have an example of petechiae. In the middle, that's purpura, and on the right, that's ecchymoses. So ecchymoses are the biggest, petechiae are the smallest, and purpura lies in between. So it's all just to do with the size of bleeding into the subcutaneous and skin tissue. So how do we investigate these patients? The first thing you want to do is, of course, if anyone's bleeding, you want to check their observations, make sure they're hemodynamically stable. So the main things to look at were blood pressure and heart rate. If they're bleeding a lot, then their heart rate is going to go up and their blood pressure is going to go down. In terms of bloods, you want to check the full blood count, and if they're bleeding, they'll be anemic. And of course, you want to check for a thrombocytopenia. Blood film might be helpful because you can assess the number and size of the platelets. In some certain conditions, the platelets have a characteristic size, which we will come on to. And bleeding time is not typically done clinically, but comes up in textbooks that evaluates the time taken to form the weak platelet plug. Okay, so the bleeding time evaluates the time taken to form the weak platelet plug that we discussed earlier. And in terms of further tests, you can do imaging or endoscopy to actually check where the bleeding is coming from. So for example, if you think this patient has an upper GI bleed, then you could do an upper GI endoscopy. So going back to the case, let's have a look at the next question. You strongly suspect idiopathic thrombocytopaenic purpura. What is the underlying pathophysiology? So we have type 1, type 2, type 3, type 4, type 5 hypersensitivity reactions. I can see some of you are asking questions relating to medications. Don't worry, that will all be discussed or rediscussed in a bit. Okay, interesting. So we have a split between type 2 hypersensitivity and type 3 hypersensitivity reaction. Good. What is the pathophysiology in ITP? Is it antibody complex mediated, or is it just antibody mediated? Or maybe, so some people say antigen antibody. So it's type 2. So it's an antibody binding to an antigen. It's not complex mediated, which is what type 3 is. So it's type 2. You have IgG against platelet antigens. That's the underlying mechanism. Type 3 is where you have antibody-antigen complexes. So you have a bunch of antibodies and a bunch of antigens all aggregating and forming complexes, which then go and deposit in tissues and cause damage. And that's what happens in lupus. Type 1 describes your IgE-mediated, most typically allergic reactions. And type 4 is your delayed T-cell mediated reactions like contact dermatitis. Type 5 isn't, some people consider it a category, some people don't, but basically it's similar to a type 2 hypersensitivity reaction. So let's look at ITP in a bit more detail. Idiopathic thrombocytopaenic purpura is also known as immune thrombocytopaenic purpura. It's a type 2 hypersensitivity reaction. You have IgG binding platelets and causing destruction in the spleen. So it's that simple. The antibody binds the platelets and then they get destroyed in the spleen. So your platelet count will therefore drop. You have two presentations, acute and chronic. Acute is the most common cause of thrombocytopenia in children. Typically occurs post-viral infection, as we had in the case earlier. So the child had an upper respiratory tract infection, and it's usually self-limiting. The vast majority of cases will spontaneously resolve. Chronic ITP is most typically seen in adults and specifically women of childbearing age. Again, it's the same mechanism, IgG against the platelet antigens, except it tends to follow a relapsing remitting course. It's not self-limiting like the acute version. The management depends on the severity and whether it's acute and chronic, but basically steroids, IVIG, and splenectomy can all be used to manage this condition. You don't really need to know about the management of any of these conditions, I'd say, but just know the basic principles. Okay, moving on to thrombotic thrombocytopaenic purpura. So what is the pathophysiology? What enzyme is affected in this disease? Good. So ADAMTS13 is reduced. This enzyme is normally responsible for degradation of von Willebrand factor. So remember, von Willebrand factor is really important in platelets binding to the damaged area of the blood vessel. If you have reduced ADAMTS13, which normally degrades von Willebrand factor, you're basically going to have too much of that von Willebrand factor around, and that's going to promote clotting. So the question is, if we're having more clotting, why is the patient thrombocytopenic? What's the mechanism behind thrombocytopenia in TTP is my question to you guys, because surely these patients are forming clots. So good, yes, increased consumption. So the von Willebrand factor, there's too much of it around, you get too many clots forming, you get multiple platelet thrombi leading to thrombocytopenia. Okay, so all the platelets are used up, not all the platelets, but a lot of the platelets will be used up in forming thrombi. The reduction in the enzyme is usually acquired, but it can be genetic. Okay, so it's usually acquired, and what we mean by acquired is you develop antibodies against the enzyme, but rarely it can be a genetic deficiency of the actual enzyme itself. It's most commonly seen in females, and it presents with this pentad. So this is the most important thing to learn about this disease. It presents with a pentad of fever, thrombocytopenia, microangiopathic hemolytic anemia, renal failure, and neurological symptoms. So, okay, we understand that these patients get thrombocytopenic. The reason they have this microangiopathic hemolytic anemia, some of you might not know what that is basically when you form lots of little tiny blood clots, as the blood is passing through those blood clots, the red blood cells will get damaged, and the red blood cells essentially end up looking this weird shape circled in blue. What are those cells called? Yeah, good, schistocytes. So these sheared red blood cells are called schistocytes, and they are damaged by the numerous thrombi in the body. And therefore you become anemic because your red blood cells are getting damaged. So these patients present with thrombocytopenia and a microangiopathic hemolytic anemia, which is what I just described. So the question is, why do they get renal failure and CNS deficits? Well, because you're forming blood clots in these various organs, and that can lead to renal failure and neurological symptoms. And that's the classic pentad of TTP that you must know. Again, you don't need to know the management in detail, but basic principles of plasma exchange. You want to try and get rid of those antibodies which are attacking the ADAMTS13 enzyme, corticosteroids and immunosuppression to try and suppress the immune response against the enzyme. And again, you can do a splenectomy as well to manage this condition. So hemolytic uremic syndrome and TTP are fairly similar in their mechanism, and it's important to understand the difference between the two. So if I ask you what organism is associated with hemolytic uremic syndrome, so I want a specific answer. E. coli 0157, that will do, I guess. That will do, that's good. E. coli 0157 colon H7, okay, that's the organism. Basically, there are various mechanisms behind this. The most common one that will be tested in your exam, and the most common form of disease seen in children is due to E. coli, okay? And this specific serotype known as 0157 colon H7. This releases a toxin known as sugar-like toxin, and that causes platelet activation and endothelial damage. You then, because you're having platelet activation and damage to the endothelium, you're going to get platelet aggregation and multiple platelet thrombi forming. You're going to get multiple blood clots forming around the body. And much like TTP, all of those, or a lot of your platelets will be consumed in those blood clots, and you end up thrombocytopenic. So the most common culprit for this organism here is eating undercooked red meat. So make sure you cook your meat properly. The difference between TTP and HUS, so HUS is caused most typically by a bacteria, TTP is caused by deficiency in ADAMTS13. So the mechanisms are slightly different. Okay. So you see a different 6-year-old and you suspect hemolytic uremic syndrome. Which of the following should you avoid? So IV fluids, oral fluids, antiemetics, antibiotics, or blood transfusion. I can see there's a couple of questions. Thank you, Azim, for answering so many of them. We'll do a Q&A at the end where I'll get to as many questions as I can. So which of the following should be avoided in HUS? Let's see what you guys think. Interesting. So we've got antibiotics and blood transfusion are our two highest answers. So this is interesting because most of you went for antibiotics, but this, as I said, this disease is caused by E. coli, which is a bacteria. So wouldn't it make sense to give antibiotics to eradicate the E. coli and therefore cure the condition? Why have so many of you gone for antibiotics? Why would you avoid antibiotics? Someone said because it's right. Oh yeah, that is true, it is right. Because if you give the patient antibiotics, you're gonna release more toxin. Let me just go back to the PowerPoint, sorry. So yes, giving the patient antibiotics can trigger release of further toxin from the E. coli. So in general, you avoid antibiotics in HUS. It depends on the clinical condition, but as a general rule, try and avoid antibiotics. Of course, you need to give the patient fluids, and that can either be IV or orally if they can tolerate it. Antiemetics are important because these patients will be vomiting, and patients may well require blood transfusion because they, as we will see, they have a microangiopathic hemolytic anemia. So as we said, the organism releases a toxin which activates the platelets. Like TTP, you get multiple platelet thrombi, and that drops your platelet count. Again, because you're forming lots of thrombi, what's going to happen to your red blood cells? They're going to shear as they go through the thrombi, they're going to get destroyed, and you're going to become anemic. So that's why you can give these patients blood transfusions if they're severely anemic. Again, looking down here, the triad is the most important thing to learn for this condition. As we said, they get a thrombocytopenia. As we said, they get a microangiopathic hemolytic anemia. They also get renal failure because you get clots forming in the kidneys. Presents with features of gastroenteritis because it's just like, you know, any other E. coli infection. You get diarrhea, vomiting, abdominal pain, and it's the most common cause of acute renal failure in children. So very important to look out for. Avoid antibiotics can exacerbate thrombi formation because you get more toxin being released. You manage it supportively, so fluids, electrolytes, blood transfusions if necessary. And in certain instances, you can do plasma exchange. So someone's asked a good question. What was it? Yeah, so why don't you give antibiotics? Because surely you need to cure the infection, but typically the infection just resolves by itself. The immune system, your immune system should be capable of tackling this sort of infection. But if it's really severe and the clinical picture is not improving, then you may consider giving antibiotics. Okay. The final quantitative or the final cause of thrombocytopenia that I want to discuss is heparin-induced thrombocytopenia. We briefly touched on this last week, but what happens is in some patients, rarely 5% or less, you give heparin and it binds to this thing called PF4, platelet factor 4 on platelets. So heparin binds to platelet factor 4 on platelets. You then have IgG, which binds the heparin platelet factor 4 complex and causes platelet destruction. The antibody heparin platelet factor 4 complexes can also damage endothelial cells and paradoxically cause thrombi formation. So the point is, you give someone heparin, they can become thrombocytopenic because you have an immune reaction against the heparin platelet factor 4 complex, but they can also develop blood clots. So strangely, it's a condition where you can get bleeding as well as blood clots. The clinical presentation typically occurs a couple of weeks after starting heparin therapy. It can occur with normal heparin or low molecular weight heparin. You can get thrombocytopenia and or thrombosis. The way to confirm a diagnosis is, number one, through the clinical presentation, and number two, you can look for the antibodies against the heparin platelet factor 4 complex. The management is just to stop the heparin. Okay, so you stop the heparin and switch them to an alternative anticoagulant if they really do need anticoagulation. Good, I hope that made sense. So this is I'd say this is probably the most important one to understand now, is medications and how they affect platelets. So we're now moving on to the qualitative disorders. So these are the ones which impair platelet function, but don't bring your platelet count down. They don't cause thrombocytopenia, but they mess up with the way the platelets function. So remember, this is what our platelets are doing. They're binding the vessel wall through von Willebrand factor. They bind each other through fibrinogen, and this is your weak platelet plug. Okay, this is your weak platelet plug here. Remember, we have ADP activates the GP2B3A receptor, and thromboxane encourages fibrinogen binding to the receptor. So how do the different drugs work? You have COX inhibitors like aspirin, which inhibit thromboxane formation. Thromboxane, remember, encourages fibrinogen binding to platelets. You have these things called P2Y12 inhibitors. I don't know who names this stuff, but basically this prevents ADP from activating the GP2B3A receptor. So what normally happens is ADP binds this receptor on platelets called P2Y12. By binding this receptor, you eventually get activation of the GP2B3A receptor and then binding to fibrinogen. Drugs like clopidogrel inhibit that process, they stop that process, and they therefore prevent activation of the GP2B3A receptor. And finally, you can have drugs which actually target the receptor itself, and they include tirofiban, abciximab, and eptifibatide. And they actually prevent the receptor directly from binding to fibrinogen. And that's all the antiplatelet drugs that you need to know, okay? You won't need to know any more than this. These are two niche diseases that might come up in your reading, so I'm just very briefly going to touch on them. Bernard-Soulier disease is where you have a genetic deficiency of GP1B, and Glanzmann disease is where you have a genetic deficiency of GP2B3A, which is this receptor here. You won't be tested on any more than this sentence here. Okay, you don't need to know any more about these two diseases for your exams. Good, so that's everything about platelets and platelet disorders that you'll probably ever need to know for your exams and even clinical practice, really. Now let's move on to something else. I can see a few good questions coming through. I'll answer them in a second. You have a 25-year-old lady presenting with recurrent epistaxis. She has a background of menorrhagia, which is poorly controlled, and says her mother suffered with the same issue. The observations are listed there. Are you worried about this patient or not worried? So we've got not worried, yes, not really, not that worried. Okay, good. I would say on the whole, the observations are pretty okay. She's bleeding, but she's not unstable. The blood pressure is a little bit, arguably a little bit on the low side, but nothing too worrying. So I wouldn't be too worried. Let's move on to the question. Which of the following is the most common hereditary bleeding disorder that this patient likely has? Haemophilia A, Haemophilia B, von Willebrand disease, idiopathic thrombocytopaenic purpura, or clotting inhibitor? So someone's asked, where would DIC fit into these diseases? Good question. That's coming up. So someone's asked, what's Glanzmann disease? Glanzmann is GP1B receptor deficiency. All the slides are online. Just trying to see the results. Okay. So we've got a split. The majority of you have gone for von Willebrand disease and the others have gone for Haemophilia A. So right off the bat, why isn't this haemophilia? What's the biggest clue in this question? What's the gender of the patient? So it's a lady, okay? Women in general, females, they can extremely rarely get Haemophilia A, but the vast majority are in males because it's an X-linked recessive condition. So that makes haemophilia extremely unlikely. And also the question has said, which is the most common hereditary bleeding disorder? The most common hereditary bleeding disorder by far is von Willebrand disease. So that is why haemophilia is not the correct answer. So von Willebrand disease, I mean, you didn't even need to know about the patient's case really, but all you needed to know is this is the most common hereditary bleeding disorder. Haemophilia A is typically seen in males, and it's not the most common. Haemophilia typically presents with bleeding into joints, okay? You get knee pain, you get, because you're bleeding into the knees, for example. You tend to present at a much earlier age because it's an X-linked recessive condition. Haemophilia B is extremely rare. Idiopathic thrombocytopaenic purpura is not the most common, and it typically presents with petechiae or purpura. Clotting inhibitor is not hereditary, it's acquired. Yes, haemophilia B is known as Christmas disease, someone has said in the chat. It's good knowledge. Okay, so what is secondary hemostasis? Secondary hemostasis, we formed our platelet plug, okay? We formed that weak platelet plug. Now we need someone to come along and make that platelet plug strong. And that's what secondary hemostasis does. It's the coagulation cascade, and it converts fibrinogen to fibrin and stabilizes that weak platelet plug. So, sorry, the coagulation cascade comes along, helps out its buddy, and stabilizes the platelet plug. It occurs on the platelet phospholipid membrane, and it requires calcium. You have two pathways, the intrinsic pathway and the extrinsic pathway. The intrinsic pathway is stimulated by subendothelial collagen and this thing called high molecular weight kininogen. And the extrinsic pathway is stimulated by tissue factor. So what on earth are these things, you might be thinking? So this is a little diagram I made earlier. The extrinsic pathway is on the left, and that involves factor 7. The extrinsic pathway is in green or turquoise, or whatever this color is. The intrinsic pathway is on the right, and that involves factor 12, and that's in light blue. All the stuff in red is known as the common pathway, okay? So we've got this green, extrinsic, blue for intrinsic, and red for common pathway. Tissue factor is a protein released upon trauma, okay? Upon damage to cells, cells release tissue factor and then activate factor 7. Remember we said when you get blood vessel damage, you get exposure of subendothelial collagen. This thing called high molecular weight kininogen is a protein in the blood. It's normally swimming along and doing its thing, but when it comes across collagen, it gets activated. So high molecular weight kininogen is then activated by the subendothelial collagen, and together they activate factor 12 and the intrinsic pathway. So those are the mechanisms behind how trauma activates your two different clotting pathways. The point is both of these pathways converge on factor 10. This is the common pathway. That's why it's known as common, because they both converge onto it. If we look at the common pathway first, you have factor 10. Once that's activated by the various pathways, converts prothrombin to thrombin. Factor 10 forms a complex with factor 5 in order to achieve that. Thrombin is an enzyme which converts fibrinogen to fibrin, and that's what we want. Thrombin also activates this thing called factor 13. What factor 13 does is it cross-links fibrin. So you have your fibrin, you have your factor 13 comes along and cross-links all of those fibrin molecules to form a really nice tight mesh. The extrinsic pathway involves factor 7, the intrinsic pathway involves factors 12, 11, 9, and 8. Okay, this bottom bit here just basically means factors 9 and 8 need to form a complex, and then they will activate factor 10. I mean, I would know the basic principles of this. It's actually quite useful to know this clotting cascade. I've tried to simplify it down and get rid of all the extra information that you may well see. One other point to know is when you have an activated factor, it has a little A written after it, which I haven't got here for simplicity. So for example, once factor 10 is activated, it's known as factor 10A. once factor 9 is activated, it's known as factor 9A, the A standing for activated. Okay. So remember up here, we had our weak platelet plug, which was connecting the platelets by fibrinogen. So this is weak. We then had our coagulation cascade come along and convert that fibrinogen into fibrin, cross-link the fibrin molecules, and you now have a really strong platelet, a really strong thrombus, which is capable of forming a blood clot and stopping bleeding. So that is secondary hemostasis in a nutshell. So how do we classify secondary hemostasis disorders? Remember, bleeding disorders can either be platelet problems or coagulation cascade problems. Secondary hemostasis disorders can be categorized into either acquired or hereditary factor deficiencies. So all of these conditions are looking at things which affect your clotting factors. And this is what we're looking at today. So the genetic ones are haemophilia and von Willebrand disease. The acquired ones are medications, coagulation factor inhibitors, disseminated intravascular coagulation, and liver failure. So let's take a look at these in a bit more detail. Clinical features first. So remember, primary hemostasis, you get early bleeding because you're unable to form that weak platelet plug. But in secondary hemostasis conditions, you are able to form that weak platelet plug. So you do have a temporary barrier which you're able to form. So you don't get early bleeding because you're able to form that weak platelet plug. But after a few minutes or even a few hours, that platelet plug will disintegrate and you will then start to bleed, because your coagulation cascade was unable to strengthen it. So you get late bleeding post-trauma. That is a classical symptom, and the classical sign is you'd most typically get deep tissue bleeding. Deep tissue bleeding means bleeding into joints, which is known as hemarthrosis. You can get muscle hematomas, for example. You can get retroperitoneal hemorrhage. So you get deep tissue bleeding, whereas with platelet disorders, it was all very superficial, things like petechiae. Okay, so we're dealing with different type of bleeding here. You can also get all the rest of it, like epistaxis, GI bleeding, etc. All of this is the same as platelet conditions. You most typically also get post-surgical bleeding and ecchymoses, so bruising. You don't really get the petechiae in coagulation cascade problems. You more get the bigger bruises, which are known as ecchymoses. How are we going to investigate this? So bedside, as before, observations, check they're hemodynamically stable, check their blood pressure and heart rate's okay, and they're not bleeding extensively. Of course, for blood count, check for an anemia because they're bleeding. And you can also check the platelets here. The platelets in a secondary hemostasis condition should be normal because it's not the platelets that are affected. The coagulation screen or the clotting screen, that's where your money's at. So you want to check the prothrombin time and the activated partial thromboplastin time. This is known as PT, and this is known as APTT. The PT looks at the extrinsic pathway, okay, which is factor 7 all the way down to formation of the fibrin clot. The APTT looks primarily at the intrinsic system or the intrinsic pathway, which is factor 12, again, all the way down to formation of the fibrin clot. And as before, further testing, imaging or endoscopy to look for where the bleeding is coming from. Let's look at haemophilia first. So haemophilia A, X-linked recessive factor 8 deficiency. So factor 8, remember, is part of the intrinsic pathway. It complexes with factor 9 to activate factor 10, which then goes on to convert prothrombin to thrombin and eventually fibrinogen to fibrin. So you have factor 8 deficiency. If you have factor 8 deficiency, is your PT going to be deranged, or your APTT? Which one of those clotting screens will be deranged? So all of you are going for APTT, which is very reassuring. That's correct. So I'm glad what I said makes sense. So it's X-linked recessive factor VIII deficiency. Haemophilia B refers to factor IX deficiency. And as someone rightly said in the chat, that's known as Christmas disease. I'm not sure why it's called that, but yeah, just an interesting fact. And haemophilia B is rare. Clinical presentation, so you typically see it in males and it can present at a young age depending on how severe the deficiency is. You get all of those things we discussed, like the deep tissue and the post-surgical bleeding. And your APTT is prolonged and you have reduced factor VIII levels. The way you manage it is you can give the patient factor VIII or you can give them desmopressin. Why desmopressin? It's a bit random to give desmopressin. What does desmopressin do in this context? Yeah, so it increases von Willebrand factor levels and it increases factor VIII levels. And that will become a bit more clearer later on. But basically desmopressin, what it does is it increases factor VIII levels. So you strongly suspect von Willebrand disease, so in this patient, sorry, we've moved on from haemophilia. We're going back to our 25-year-old lady with recurrent epistaxis. Remember, we said what was the most common cause of a hereditary bleeding disorder, and it was von Willebrand disease. Going on to the Menti questions, which of the following would you most expect? In von Willebrand disease, which of the following would you most expect? Increased PT, reduced PT, increased APTT, reduced APTT, or none of the above? Okay, increased APTT. Good, that's the correct answer. Let's have a look at why that is. So in von Willebrand disease, you lack von Willebrand factor. If you lack von Willebrand factor, you therefore cannot stabilize factor VIII. Okay, von Willebrand factor is crucial in stabilizing factor VIII. So if you have a lack of von Willebrand factor, your factor VIII will be affected and therefore your APTT will be raised. Because remember, APTT looks at the intrinsic pathway, which involves factor VIII. Don't worry, we'll come on to this. There'll be a diagram coming up which explains it a lot more clearer. So that's why this is the correct answer. Looking at von Willebrand disease in a bit more detail. So it's an autosomal dominant condition on the whole. There are multiple different types. We'll focus on primarily type 1, seen in 80% of patients, and you have reduced von Willebrand factor. Type 2, the von Willebrand factor levels are normal, but it's a qualitative defect. So it doesn't function properly, but the actual number of, or the amount of von Willebrand factor is normal. And then you have type 3, which is a complete absence, and that's autosomal recessive. So remember, von Willebrand factor is a protein. What does it do? It binds to the exposed subendothelial collagen, and it binds to platelets via the GP1B receptor, allowing platelets to stick to the affected area of the blood vessel. Remember, you have trauma. Trauma causes exposure of that subendothelial collagen, and that stimulates this whole process. So the confusing thing here might be, well, how is this affecting the coagulation cascade? Surely this is a platelet disorder because von Willebrand factor binds the platelets. And if you have less von Willebrand factor, then that's surely going to affect platelet aggregation and adhesion. So whilst that's true, so remember I just said von Willebrand factor stabilizes factor VIII. So if you have a deficiency of von Willebrand factor, you're going to have a reduced factor 8 half-life. So your factor 8 over here is going to be reduced, and that's why your APTT is prolonged, because APTT looks at this intrinsic pathway over here. So the point is, reduce von Willebrand factor, reduce factor 8, and therefore a prolonged APTT. You'll also have reduced factor 8 levels for reasons I just discussed. There's this special test called a ristocetin assay, which looks at the ability of the platelets to clot together and clump together, and that will be reduced in von Willebrand disease, because remember, von Willebrand factor helps all the platelets sort of clump together. So you'll have failure of agglutination. You'll also have an increased bleeding time, because von Willebrand disease does also affect the platelets. The time taken to form that weak platelet plug will be increased, which is what an increased bleeding time means. And it's the most common hereditary coagulation disorder. Again, you don't need to know the management in much detail at all. You can give desmopressin. Desmopressin stimulates von Willebrand factor release. You can give the patient factor 8. You can give the patient some von Willebrand factor as well. Right. So we'll finish off in the next 10 minutes or so, hopefully. Looking at the acquired coagulation cascade diseases, we first want to focus on medications. So again, this is really important to understand. Warfarin, heparin, and direct oral anticoagulants. What is the mechanism of action for warfarin? What does warfarin do? Good, so vitamin K antagonist. Warfarin blocks vitamin K activation. Why is that important? Well, there are a few vitamin K dependent coagulation factors. The way to remember it is 1972 CS. So factors, the 1 stands for 10. So factor 10, factor 9, factor 7, factor 2, protein C and protein S. That's the mnemonic. We haven't discussed much about protein C and S today. We'll discuss that in the next lesson where we talk about thrombophilia. But the point is, all of these factors require vitamin K to work properly. Factor 10, factor 9, factor 7 over here, and factor 2 is prothrombin. Okay, factor 2 is another name for prothrombin. All of those factors require vitamin K. What warfarin does is it blocks the action of vitamin K, and so those factors don't work properly. If those factors don't work properly, therefore, you're going to be more prone to bleeding, which is exactly what we want patients to be when you start them on warfarin. The way you monitor it is with the INR, the International Normalized Ratio, which is just a standardized measure of the prothrombin time. Okay. So the question I have to you is, why do we use prothrombin time, or a measure of the prothrombin time, rather than APTT with warfarin? Good, because of the factor 7 is being affected. Okay, so remember factor 7, I know factor 9 is also affected, but factor 7, factor 10, factor 2 are all affected. So that's a big part of the extrinsic pathway. The APTT will also be a bit deranged because factor 9 is affected, but in general, we use the prothrombin time to monitor warfarin. And that's primarily because of the effect on factor 7. Remember, the prothrombin time looks at the extrinsic pathway. How does heparin work? It's an antithrombin 3 activator. Antithrombin 3, what does that do? Well, it blocks the action of thrombin, as well as a few other clotting factors like factor 10. So antithrombin 3 blocks thrombin, and so you don't get this conversion from fibrinogen to fibrin. Some of you might be thinking, or you may have heard of, heparin and low molecular weight heparin and what the difference is. So heparin is given intravenously and it has a short half-life. Low molecular weight heparin is given subcutaneously and it has a longer half-life. So for those of you who've ever seen heparin given, it requires intense monitoring every couple of hours. It has a very short half-life, and that's useful for instances where you don't want the patient to be anticoagulated for long periods of time. So an example of that would be just before surgery. You don't want the anticoagulant to be sitting in the blood for a long period of time. So you give them an anticoagulant with a very short half-life, like heparin, IV heparin. Low molecular weight heparin has a much longer half-life. APTT is used to monitor IV heparin. Low molecular weight heparin doesn't normally require monitoring, but very occasionally you can use something called anti-factor Xa. But on the whole, low molecular weight heparin doesn't really require monitoring. DOACs, what do they stand for? Direct oral anticoagulant. You have two types. You have a thrombin inhibitor and a factor Xa inhibitor. And the actual mechanism of action is mentioned in the name. So dabigatran, BI, bi means two. Remember, prothrombin is factor 2. So that's how you know dabigatran is a thrombin inhibitor. Dabigatran blocks the action of thrombin and therefore blocks the conversion of fibrinogen to fibrin. Again, factor Xa inhibitors have Xa in the name. Apixaban, rivaroxaban, and edoxaban. They all block the activated version of factor 10. They do not require monitoring, but the downside is they can be tricky to reverse. So if a patient comes in bleeding and they are on a DOAC, it can be tricky to reverse the anticoagulation. And this is the final one we're going to go over today. I'm not really going to go into disseminated intravascular coagulation because we've discussed that in depth in my sepsis lecture. So go and have a look at that if you want to know more. Coagulation factor inhibitor is where you have an acquired antibody against a specific or multiple coagulation factors, with anti-factor VIII being the most common. It's commonly seen in hemophiliacs who receive factor VIII. Giving the patient factor VIII stimulates the body to make antibodies against factor VIII, which is actually a bit of a nightmare because now the patient has formed antibodies against the treatment that you're trying to give them. The clinical presentation depends on the affected factor, so they'll have all of those features like the deep tissue bleeding, post-surgical bleeding, etc. Whether the APTT or the PT is deranged depends on the specific factor affected. And mixing studies is how you diagnose coagulation factor inhibitors. So what you do is you get some normal plasma, which contains normal coagulation factors. So normal plasma from a donor, which contains all of the normal clotting factors, and you mix it with the patient's plasma. If you have no correction of the clotting studies, that means that the patient's plasma contains antibodies which are attacking the donor clotting factors. If you do have correction of the coagulation screen, the PT or the APTT, that simply means that the patient just had decreased production of a specific factor. So that's how you differentiate between an antibody-mediated process, which is also known as coagulation factor inhibitor, and decreased production of clotting factors. So just to go over that one more time, because that's quite important to understand, you get a normal plasma and the patient's plasma, and you mix them together. If you have correction of the PT or the APTT, that just means the patient was lacking a particular coagulation factor. If you don't have correction, that means the patient has antibodies which are attacking the donor plasma and attacking the donor clotting factors. Okay, so let's look at the top decile question before we finish up. And please do stick around for the feedback form as well, because we are very appreciative of all of your feedback, and that really helps us improve the process. And the other thing is we have our quiz on August the 19th. So I think that's next week. That will contain 40 questions. Some of them will be top decile. Some of them will be slightly easier, covering a lot of the concepts we've gone over in the previous webinars. And if you come top, you get a £100 prize, lifelong subscription to our website, and a BiteMedicine mug. I'll give you a few more seconds to enter. So the quicker you answer, the more points you get. Which of the following enzymes does warfarin inhibit? I didn't give you much time, sorry, that was a bit unfair of me, but most of you already answered anyway. Okay, epoxide reductase. It wasn't as hard as I thought. Obviously, you guys are very smart. So epoxide reductase is the enzyme it inhibits. Vitamin K oxidase is something I just made up. So well done, Smiley. Well done, all of you guys. You all did really well. Remember, tune in to our quiz next week, and if you win, you'll be up for a prize of £100. But let's just finish off the last few slides. So which of the following enzymes does warfarin inhibit? It inhibits epoxide reductase. Epoxide reductase is the enzyme responsible for activating vitamin K. If you block that enzyme, you block vitamin K activation and you reduce the function of those vitamin K dependent coagulation factors. Remember the mnemonic 1972 CS. Here's a recap, and this is quite important, this table actually, but the point is primary hemostasis forms a weak platelet plug. Secondary hemostasis comes along and stabilizes that platelet plug. Bleeding in platelet disorders is superficial and it occurs early on. In the coagulation cascade disorders, you get deep bleeding and you get late bleeding. Petechiae is more associated with platelets. You can get purpura and ecchymoses in both. Hemarthrosis, so bleeding into joints, is classically associated with coagulation cascade disorders. And you can get all of these, epistaxis, etc., in both disease types. The next session, we're going to cover the fibrinolytic pathway and hypercoagulability and thrombophilias. So those, I saw some of you were asking about factor V Leiden, etc. That will all be covered in the next session. That does not fall under a bleeding disorder. Okay, check out our question bank. We have a bunch of case-based questions like we've covered in this webinar, where you go right from the first steps, taking you through to the management. And we do have quite a few hematology questions. And again, check out our textbook where we take you from the pathophysiology through to the complications of each topic. We have a bunch of free material on there as well, so do check that out. And that is the QR code for the feedback form. I think Azim's going to post the link, hopefully. I will do a Q&A now so I can answer some of your questions. I know there's quite a few. Okay, let me look through some of these questions. What is the cause of ITP? It's a good question. So the cause of ITP is IgG against the platelet surface, antigens on the platelet surface. That causes destruction of platelets. So it's a type 2 hypersensitivity reaction. Thank you all for your very kind words, by the way. It's been an absolute pleasure teaching you, and it's actually really hot for those of you who are living in London. So I really appreciate if you have tuned in despite the weather. Can I have a date with Azim instead of 100 if I win? Absolutely. Absolutely, you can. That's a great idea. Where do the antibodies come from in ITP? They come from the spleen. Is menorrhagia considered as deep tissue bleeding or superficial? I mean, I guess it's the endometrium, isn't it? So it's not particularly deep tissue, but you can. The point is, you can get it in platelet disorders, or you can get it in coagulation cascade disorders. It's not really specific to either. Please, can we have the feedback form link? I think Azim has just posted that. Are you planning on covering liver failure? We will definitely cover liver failure at some point. If giving antibiotics for E. coli will make it release more toxin, does that mean each time you treat a bacterial infection with antibiotics, the bacteria release toxin? So the point is specifically for what is it called? Hemolytic uremic syndrome. Studies have shown that if you give, they're more in vitro studies, but basically studies have shown that giving antibiotics can worsen the condition. So that's why, ultimately, that's why we try and hold off giving antibiotics. For other infections, like simple chest infections, etc., studies have shown that giving antibiotics really does improve the condition. So we give antibiotics in those conditions. Okay. Thanks for the lecture. You are very welcome. Would it be possible to go over electrolyte abnormalities like hypokalemia and hyperkalemia? Absolutely. We need to get around to that. That's an important topic. Thank you for bringing that up. How to differentiate between the different types of MAHA. So MAHA can stand for two things. It can stand for microangiopathic hemolytic anemia or macro. So micro or macro hemolytic angiopathy. Microangiopathic hemolytic anemia, sorry. So macro is caused by prosthetic heart valves, and micro are caused by multiple thrombi like you get in TTP or HUS. The way you differentiate between them depends on the clinical presentation of the patient. If you know the patient has prosthetic heart valves, that's your answer. If you know the patient has come in with gastroenteritis and they have acute renal failure, then you know they've probably got HUS. So it just depends on the clinical presentation. I will go over one or two, I'll go over a couple more because there's still quite a few of you here. When would you consider child abuse? That's a good question, actually, especially in a patient who's come in with bruising. If I saw a patient with profuse bruising, I would consider child abuse straight away. But I mean, you'd obviously have to look at the interaction between the patient and the parent. You'd have to check their blood tests. And if their blood tests suggested some hematological disorder, then obviously that would point you away from child abuse. But you need to take the whole clinical picture into account. Could you run over the mixing studies again? Yes, I can. So the mixing studies where you get normal plasma and you mix it with the patient's plasma. If the patient has a factor deficiency like in haemophilia and you're giving them normal plasma, what's going to happen to the PT and the APTT? It's going to fix itself because you're adding more coagulation factor in. If the patient has an antibody against a specific factor, no matter how much donor plasma you give them, that antibody is just going to destroy all of those additional factors you're giving them. So you will not get correction of the PT and the APTT. So hopefully that makes sense. All right, I'll probably take one more. See a lot of nice comments. You're all very welcome. There's a question about HSP. HSP it's a vasculitis, doesn't really fit into this. It's an IgA-mediated vasculitis where you get renal failure. You do get purpura, and you can, you do have an increased risk of bleeding in that sense, but it's not typically considered a primary or a secondary hemostasis condition. I think we'll probably leave it there. Thank you all so much. PS, these webinars are awesome. You're very welcome. If you do have any further questions, just post them in our Facebook group, or you can email me at shuaib@bitemedicine.com. Just try and reach out to us and we'll be happy to answer. And we always love to read your feedback. Do let us know how we can improve, and tune in for our quiz next week. And Azim is doing a session this week as well. So please do tune into that.